All right, Madam Chair, we're all set.
All right, thank you very much. So we're going to start this forum, informational forum regarding the state's adult behavioral health system. I saw Representative France. Do you want to make a few comments?
Morning, Madam Chair. Just looking forward to the presentation from the Commissioner and learning more about where we are with behavioral health in our state. Thank you.
Thank you. I don't know if Senator Minor or Representative Walker are on yet. I know they will be on, but everybody's getting ready for session, and so everybody has a ton of different meetings going on, as I know our presenters do also. So just so everybody is aware, we'll have presentations from several commissioners and their staff, and then we'll have questions at that point. So first up, and I hope everybody's enjoying the weather and staying warm. I think it was Representative Kennedy who told us that she is in 85-degree weather. And I don't know that we should talk to her at all today because she's in 85-degree weather. So we'll just ignore Representative Kennedy today. No, not really, Representative. We'll live vicariously through you. First up is we have the Acting Commissioner, Nancy Navarrete, from the Department of Mental Health and Addiction Services. Good morning, Commissioner, and if you want to let us know who on your team is here and then do your presentation, that would be great.
Sure. So I think Christine Goldrick is going to share her screen for the actual slideshow. So she's one of our fellows from the Office of the Governor. And I have my fiscal team here, Cheryl Aurora, Stephen DePietro, Mary Kate Mason, Legislative Liaison, program folks, Julian Giard, Kim Caranda, Chris Burke, and Amy Maracino. And hopefully I didn't leave anyone out. Okay, so good morning, everyone. Thank you, Senator Austin and distinguished members of the Appropriations Committee. I am Nancy Navarrete. I'm the interim commissioner at the Department of Mental Health and Addiction Services. Really welcome this opportunity to talk about the mental health system in
our slides
in Connecticut.
Okay,
Excuse me. Mr. Bronson.
Oh, okay, I got all nervous for a second.
Mr. Bronson, if you could mute, thank you. Go ahead, Commissioner.
Sure. So I welcome this opportunity. Adult behavioral health is one of my favorite things to talk about, and it's very important to me. So I'm going to provide a very high level overview with a focus on some special populations that you all had asked to hear about, namely young adults and forensics. I'll also go over some of our priority areas, which are access, integrated care, and crisis response. And then we'll look at some funding levels for mental health and substance use programming. Christine, can you cue the slides back? Thank you. So if you can go to slide 3. So when we talk about adult behavioral health, I want to make sure everyone understands that that includes both mental health and addiction services. And overall, Connecticut does stand out as a leader in the delivery of recovery-oriented behavioral health services. So to provide some context on the left there in blue, you can see that about 19% of adults in Connecticut live with mental illness. About 8.4% of adults in Connecticut live with substance use issues. We know definitely during the pandemic that there was an increase in anxiety and depression, especially among minorities and low-income households. So we're taking a look at that. Surprisingly, and good for Connecticut, there was a decrease actually of death by suicide by 16% from the previous year in the adult population. Now, the numbers for fatal drug overdoses in 2020 was 1,378. We don't have the numbers yet for 21, calendar year 21, but we are expecting those to go up a bit. So how do we compare nationally here in Connecticut? Well, we're ranked number 4 in the United States for access to adult mental health care. When you add in lifespan, when you add in pediatrics, we are number 9. And we have over 3,000 behavioral health beds. So inpatient and residential care, those are 24/7 beds that are available in the system. We also actually operate 5 different facilities that are hospital level of care. So our 2 main hospitals on the Middletown campus, and then 3 other sites have units. So Capital Region in Hartford, CMHC in New Haven, and Southwest in Bridgeport. And our substance use hospital level of care is at Middletown, with the campus at Blue Hills in Hartford as well. So we serve approximately 100,000 clients, with 10,000 of those clients served by our forensics unit. Next slide. So the Department of Mental Health and Addiction Services provides a continuum of services for adults over the age of 18 who are living with behavioral health issues. Those folks are usually underinsured or uninsured. And for the purpose of this presentation, when I say Demus Services, that really includes both the state operated and the public partnership with the state operated and the private nonprofits. So we contract with over 100 private nonprofits, 134 actually. And as I mentioned before, we do prevention, treatment, and recovery supports. Our prevention programs are lifespan. So 0 through 99, we do prevention, mental health, substance use, and lifespan. I mentioned the beds because folks are interested in this, but this is only part of the continuum. So we believe individuals should be served at the least restrictive level of care in the community. And usually that looks like outpatient services and supportive services. So that can be around employment, housing support, care coordination, peer support. We're actually also a leader in peer support nationally. So we've embedded individuals with lived experience in the recovery process every step of the way. And if you look at our overall budget, state and federal, we're approximately 80% of our program budget addresses mental health, and approximately 20% addresses substance use. So as we review some of the special populations, keep in mind that clients have access to all of these services that we're talking about, regardless of what their identified complexities are. Next slide. So this slide provides a look at what Connecticut residents have access to. So it's a bigger picture. The behavioral health landscape is bigger than Demus. So Demus typically provides services to Medicaid insured individuals. And as the complexity of the issues that people struggle with increase, our funding increases. So if you look at this diagram, you can see that the entire space is nonprofit providers, which our lifespan can include clinics in your community, FQHCs in your community, hospitals, private practitioners who usually see commercially insured or people who are paying out of pocket. And those folks, those providers usually work alone or in small group practices. And then our interagency partnerships. So there's a subset of individuals that you'll hear about today who receive behavioral health services within DOC, within CSSD, for example, and they intersect with Demus. So our strong partnerships with our sister state agencies helps us avoid duplication of services and ensures good stewardship of the public funding. So I'll give you an example. That would be, so individuals on probation, for example, CSSD may contract with providers in the community who are oftentimes the same providers that we're contracting with and we do business with. Treatment for opiate use disorder in the Department of Correction. Another example of a partnership that goes back several years, that started in jails in New Haven and Bridgeport and has expanded under DOC leadership across the state to all of their correctional facilities. And then the orange section on the left is depicts the Demus providers. So as a side note, the entire system is experiencing what I'm sure you've all heard about, a workforce shortage, issues with the workforce. We've heard a lot about it. From all of these providers listed here. We were allocated $15 million in ARPA funding to address the 4% COLA, and all but 2 payments are out on those dollars. So that is out in the world as we speak. Next slide. So access to behavioral health care. There's no wrong door in accessing the Demus behavioral health system. The system has many points of access, each emphasize patient choice. So you can reach us by phone, you can access services. We have 24/7 hotlines for substance use, for through 211 for mental health and resource information, for mobile crisis information, online access. So we have front-facing websites that list our census, both for addiction and for mental health. So a consumer can look there and see what's available. And also the programmatic umbrella of the LMHAs. So we have 13 local mental health authorities, each with a catchment area. They can be reached directly, as well as our many statewide programs in the substance abuse space. We know that healthcare is complicated, and we have made accessibility a priority for the department moving forward. We've introduced low barrier treatment, such as street psychiatry, mobile medication, assisted treatment for opiate use disorder and other substance use disorders, recovery support, recovery coaches, and navigators in the community. So if you can't come to us, we will come to you. And I think you're going to be seeing more and more of that model. Next slide. So we were asked to highlight young adult services and what's available in the system. So what we call YAS, Young Adult Services, serves high-risk young adults between the ages of 18 and 25. And so while we served 1,197 individuals under the YAS programming, we serve way more than that in this age range. So 12,000 individuals age 18 to 25. The YAS folks are the folks that need the most intensive level of services. And this includes youth transitioning out of the Department of Children and Families, as well as CSSD. And we receive referrals from Beacon and other community sources across the state. So you can see that services and supports are available from everything from transitioning from DCF to employment support, even specialized reproductive health and perinatal support. We have MOUs to assist in transitioning from the juvenile justice system into community-based residential programs. So our work with our state partners, with our work and our MOUs, we can actually start outreaching to individuals as young as 16 and start that process so that when 18 comes along, it's not a switch that turns on and off. People become familiar with service providers. They have a clear treatment plan, and whatever we can do to make that transition easier for the individuals that we serve. We address eligibility, engagement, and transition planning. There is a YAS team at each one of our LMHAs, and we know that early intervention can mitigate the severity of future disability, increase the potential productive activities, and avoid adverse consequences. So we have a strong focus, of course, on healing from trauma, learning life skills, independent living, and participation in the community. On the right-hand side there in yellow, you can see that we've highlighted what we've done with caseload growth this year. We're adding 22 community beds into the system statewide. We've added a recovery support specialist, funding additional resources so that young people can access the support either online or telephonically, and that's available through turningpointct.org. And as I mentioned, we have MOUs with Beacon CSSD in addition to DCF. Next slide. So you also asked to see the budget across a couple of years, and this is the YAS funding by source. So the dark navy is the state funding, and the yellow is federal, generally federal funding. So it's gone from 76.6 million to 85.5 million, which is projected for fiscal year 23. Next slide. So the next 4 slides are going to give you an overview of the adult mental health program and budget and the substance use program and budget. So once again, I'll mention the continuum of services, including some of our core mental health programs. So things that you're familiar with, like social clubs, ACT teams in the community, housing supports, first episode psychosis programming in New Haven and in Hartford, which we hope to expand statewide. Employment and recovery support services statewide, people with lived experience embedded in every level of care. If you go to the mobile crisis box, this is our crisis response is another priority for the department. And part of that response are our mobile crisis services. So we have 18 mobile crisis teams, which cover the entire state. We've expanded them with federal funding and with state funding. So we received an additional 2.5 million in the state budget for fiscal year 22 and 23. That will be distributed across 7 of our PMP providers. We are approaching 24/7 ability to deploy people to the community. We're not quite there yet. Of course, there's telephonic support 24/7, but on some shifts, we're not able to deploy a person. We have strong collaborations with law enforcement, and you can reach us, again, no wrong door, either by calling directly if you have a relationship with the LMHA or by calling United Way 211. Next slide. So this gives you a picture of our budget over 3 years for mental health. You can see 460 million to 480 million. The yellow, the state is the navy, the block grants is the yellow, and then we do apply for discretionary funding. So there are grant opportunities federally that Demus has a very strong track record in getting awarded, and that's what you see in the lighter blue. Next slide. So this is a snapshot of the adult substance abuse program. We are the lead agency for prevention and treatment of substance use. We have over 200 community-based substance use programs. We, of course, have the hospital level of care out of our Middletown campus and Blue Hills campus. We served about 40,000 clients in state fiscal year 21. Note again the continuum of services. We've put a tremendous amount of investment in promoting medication-assisted treatment, which you may know is an evidence-based practice to treat opiate use disorder. So we've provided training, support, mentorship, startup funds to provide access to the medication, and we've really come a long way. We've worked with DOC, with other behavioral health practitioners across the state to really get the word out about MAT. Prevention plays a significant role, as does harm reduction, as we combat the opioid crisis. So we fund recovery centers, harm reduction centers, Narcan distribution into communities through our regional behavioral health action organizations that you're familiar with. Our recovery partners have been successful in providing statewide access to recovery coaching, telephonic recovery support programming. And to the right, we've highlighted some of our stellar peer support programs. So our peers in the ED has been nationally recognized and really was the basis for some federal legislation. They have a 90% connect to care post-hospital discharge or ED use. So that care is whatever the person chooses. That could be recovery supports, it could be withdrawal management, it could be ongoing individual and medication management, whatever makes sense for that person. We have other specialized peer programs. We have one program called REACH that specializes in supporting pregnant and parenting women, their children and their families, anybody in their family. So really a systems approach to wrapping services and care coordination around people. They've served over 1,500 clients since March of 2019. And we have, as I mentioned, we have peers integrated at every level of care throughout the Demus system. Next slide. So again, a snapshot of substance use annual funding by source. So you see, again, the Navy is our state funding, and we have more block grants going towards substance use than mental health. So the orange becomes a little more broad. And then the lighter blue is our discretionary funding that we've applied for and been awarded. So that the total has gone from 94 to 96.7, almost $97 million over a 3-year period. Next slide. So we've talked about access, crisis response, and a third departmental priority is integrated care. So I believe, and the department believes, that individuals should be able to receive all of their behavioral health services under one roof. So that means addictions and mental health. There's no reason folks should have bifurcated care and have to go to different providers. We really take a whole person approach. We also find that people living with mental illness will die on average of 25 years younger than someone without mental illness. So that's a scary statistic. And to that end, care really must be provided in a nurturing, stigma-free environment with a professional who understands psychiatric illness or substance use, as well as the medications prescribed to treat those disorders. So many of or a handful of our LMHAs have primary care access on site, both state operated and PNP. There's a mix there, but we're really looking to expand that model. It's really, I believe, the safest way for our folks and the most effective way for people with serious mental illness to receive whole person care. I've highlighted below some of our co-occurring integrated care projects. We've invested additional dollars in one of our most intensive levels of care, which is the level of care in residential that provides up to 30 hours or 30 hours a week of treatment services. We want to make sure that folks accessing that program have the additional resources to provide the mental health treatment. We've also enhanced services in our pregnant and parenting women's substance use disorder programming. We've coordinated care with pediatricians, OB, reproductive health, addressed trauma and attachment issues, mom and baby, and family systems issues as well through those programs. We have an expectation that all of our outpatient providers provide access to MAT, medication assisted treatment, and vice versa. So if you are a substance use provider, we also expect that you will have an ability to connect people for psychiatric assessment and treatment moving forward. One of our really stellar programs is Behavioral Health Home, and that's a care coordination initiative which focuses on whole person services. Really pay attention to those, to physical health, engagement into preventative care, increased access to, as I mentioned, preventative care, improving health outcomes, improving patient satisfaction and quality of the services received, decreased use of higher levels of care, so emergency room and hospital level of care. And really, we've shown over the past several years a cost savings using this kind of model. Next slide. So lastly, Demus has an array of services designed to increase compliance with criminal justice supervision, eliminate or reduce the need for incarceration, and reduce criminal recidivism. We utilize collaboration of criminal justice and behavioral health systems with specific strategies to connect people to services at each point in the criminal justice system. So that includes diversion, consultation and evaluation, acute and rehabilitative hospital services, community and reentry services. We serve over 10,000 people annually, and our jail diversion program for individuals with mental health who pose a low risk to the community is really held up as a national model. In the yellow box, you can see I've highlighted some of our programs. The Enhanced Forensic Respite Beds is a brand new program. It's a collaborative with Demus, DOC, Judicial, and our private nonprofit regional network of programs. And it diverts clients entirely from incarceration and hospitalization, while at the same time reducing the numbers of competency to stand trial orders. So with our jail diversion and reentry services, it really contributes to Connecticut being one of the very few states that do not have hospital wait lists for restoration defendants, and we're not seeing an increase in the number of cases there. So again, another highlight on Connecticut. Next slide. So this is the last slide, and this gives you a bird's eye view of the budget for our adult forensic programming. A small amount of federal dollars, mostly state dollars, 90 million up to almost 94 million projected for fiscal year 23. So I think I've covered all the topics that you've asked to hear about. Certainly happy to take questions at the end of everyone's presentations. So I turn it back to the moderator.
So, thank you very much, Commissioner. Commissioner, I noticed that when your slides came up, they said that there were 47 slides. Are there other slides on here that give us additional information, or is this the compilation of everybody all together?
It's everybody all together.
Okay, thank you, Commissioner.
You're welcome.
Up next is Commissioner Gifford. Commissioner, do you want to introduce your staff?
Yes, thank you, Senator Austin and members of the committee. Thank you for hosting this forum on this really, really important topic. I'm Deidre Gifford, the Commissioner of the Department of Social Services. I'm joined this morning by Bill Halsey, who is our acting Medicaid director and also has for many years been directing the adult and child behavioral health programs for the Department of Social Services and is himself a behavioral health clinician. So I'm going to give a couple of introductory remarks and then turn the remainder of our slides over to Bill. Next slide, please. So this really describes the spectrum of services that are provided to individuals in Husky in behavioral health. For context, you heard Commissioner Navarrete say that there are about 526,000 adults in the state of Connecticut who have a mental health condition. In Husky, we have 638,000 adults enrolled, and of those, 36% accessed a behavioral health service in the year before the pandemic. So that means about 230,000 Husky members used a behavioral health service in that year. So about half of the adults in Connecticut that have a behavioral health condition are covered by Husky. So it's a really critical component of the mental health coverage system in Connecticut, and we're very proud of the continuum of services that we provide in Husky for behavioral health. And as the commissioner mentioned, a significant portion of the services that they fund are used for Medicaid beneficiaries. So beginning on the left with screening and brief intervention, This is a service to help identify individuals who may be undiagnosed or may have not shared that they have a mental health condition. And I would even go a little bit further to the left on this arrow and talk about some of the work that we have been and are looking to do on prevention. So we've been talking about our services in universal home visiting and community health workers for families with young children. And that work is very much aimed at identifying and mitigating and trying to prevent adverse childhood experiences, which can lead to both childhood and adult mental health challenges. So we're working on prevention as well as screening. And then you heard Commissioner Navarrete talk about a whole person approach to behavioral health. And we're very much interested in continuing our work along with the Office of Healthcare Strategy and Demus and DCF on the integration of primary care and behavioral health services. We know that people find it much easier to access mental health services if they are combined with their physical health services. And so we have been working through our patient-centered medical home program and others to assist providers in having on-site or other easily accessed behavioral health services within primary care. And then the remainder of these services on the continuum are focused on more intense services. We can provide services in the home for individuals who, through waiver services, need to access them there. A very wide spectrum of outpatient services, both everything from individual to group to more intensive services, then inpatient partial hospitalization and intensive outpatient services, residential services, and then inpatient hospital services when needed, but very much focusing on the screening, prevention, and providing the services in non-institutional settings whenever possible. Next slide. So we wanted to give you an update this morning on where we are in terms of short and medium-term interventions to enhance our adult behavioral health coverage in Husky. So I'm going to turn over to Bill Halsey now, who's going to walk through these various initiatives. We just, Senator, have a couple more slides, and then we'll be happy to take questions. Over to you, Bill.
Thank you, Commissioner, and good morning, everyone. So these are our current or short-term initiatives. So we have recently expanded enhanced care clinic sites. So we have several enhanced care clinics for both children and adults, and we have recently allowed those clinics to expand the number of sites designated as enhanced care clinics. We have an expedited eligibility system in Medicaid for individuals being released from a DOC facility. This is especially important. We still are in the midst of an opioid epidemic, and the faster we can get somebody on Medicaid after being released from a prison, the faster we can get them into treatment and potentially on medication to avoid overdoses. We recently implemented a 4% rate enhancement for employee compensation under Medicaid. And then, as many of you know, we have been working with our state partners, DCF and Demus and Judicial Branch and DOC on a substance use disorder residential treatment waiver. We have all of our documentation into CMS, and we are waiting for their approval, and we are hoping for a go live date in the final quarter of state fiscal year 2022. Next slide, please. So some medium-term initiatives. You're going to hear about mobile crisis quite a bit. There is an opportunity under Medicaid for enhanced match if we improve and expand mobile crisis services, both on the kid side and the adult side. Again, there is a multi-state agency work group working on that. That opportunity becomes effective on April 1st. We've also, again, multi-state agency work group, been working on outpatient services. So we really want to enhance our outpatient provider network and give them the tools necessary to prevent hospitalization and ED visits, and incorporating care coordination, including peer work, into outpatient services in a more formalized way. And as the commissioner said, both commissioners said, we want to make sure that behavioral health services are accessible. And so there really are at least two models. There's access to mental health services, behavioral health services in your primary care setting, or building capacity on the behavioral health side to provide primary care services. So we just want to make sure that individuals can get both primary care and behavioral health care in one setting. I believe Commissioner Navarrete talked about the model where behavioral health providers have expanded capacity in the primary care area. And we're also interested in building capacity in the primary care side so they can provide behavioral health services. And I think that does conclude our slide deck. Next slide, please. Yes. Thank you.
Thank you very much. Judge Carroll, I believe you're up now.
Good morning, Senator Austin and everyone else who's on the call. I'm Pat Carroll. I'm the Chief Court Administrator. As you're going to see, we have an extensive network of behavioral health resources available within the judicial branch to individuals who are both in pretrial status and in probationary status. Most of our resources are administered in cooperation with Demus, DOC, and other agencies at both the state and municipal level. And they have historically proven to be extraordinarily cooperative and collaborative relationships. All of our behavioral health resources are managed by our Court Support Services Division. I'm going to turn the presentation over at this point to the Executive Director of our Court Support Services Division, with whom many of you are familiar. That's Gary Roberge. And Gary's going to tell us about what resources are available within the branch and what do we perceive to be our challenges going forward. So Gary, I'll turn it over to you.
Thank you, Judge Carroll, and thank you, Madam Chair and members of the Appropriations Committee for the opportunity to present. And thank you, Commissioner Navarrete, for coordinating this presentation today for all of the agencies that are participating. So I just want to start. Can we go to the first slide, please? Okay, so the way we've structured this presentation is we're going to take a look at pretrial and then post-conviction, as Judge Carroll noted, those under adult probation supervision, and how behavioral health intersects with the courts and the services that we have available to address those issues that we identify. And I just wanted to give us some context around numbers that we're talking about. So in fiscal year, well, the adult court is for 18 and older. And if we do get 15, 16, or 17-year-old transfers from the juvenile court, we still work with DCF and our juvenile contracted providers to provide services for those kids that may be transferred and in need of services in the community. So we're talking basically 18 and over here. And in fiscal year 2021, we did 19,428 arraignments. Now, those are lockup arraignments. So individuals that are arrested by police departments, held on bond, and then ultimately make their way to lockup. And that's significantly less than years past and pre-COVID, right? Traditionally, that number is between 35 and 40,000. So it's almost half of what we were seeing pre-COVID. The next line is the domestic violence arraignments. So 22,800 of those. A subset of those, approximately 25%, are in that 19,000 number above. And then we also have completed 12,928 post-arraignment assessments on those domestic violence cases, because referrals for behavioral health services can come at either of those instances in the process. Adult probation, again, 18 and older, unless transferred from juvenile up. And currently we have 29,514 people that we're supervising on our probation supervision. Again, I've been with the branch 34 years, and I think this is the first time that I can recollect that we're under 30,000. That's a good thing. That's not a bad thing. And then I just mentioned that we have specialized mental health probation caseloads, where we had almost 1,000 individuals supervised by specially trained officers. I'll talk about that throughout the course of the presentation. And then the supervised diversion program, which I'll get into in the next slide, we have 562 clients in that program on the last day of fiscal 21. Can we go to the next slide, please? So pretrial services. So those are the lockup arraignments and the domestic violence cases that we were talking about. We have the supervised diversion program, which is much like accelerated rehabilitation for the lower level behavioral health services that a defendant may need. And they're screened through our behavioral health network that I'll talk about in a little bit. Defendants that are eligible for this program and are admitted by the court receive enhanced supervision through probation officers that are specifically trained for supervision of this caseload, and in working and collaborating with the local mental health affiliates, our adult behavioral health providers that provide behavioral health services. And you can see there were 437 referrals to the SDP program this past fiscal year, and which again is pretty much half of what we had pre-COVID. And it's just a instance of, the number of cases that are being heard and screened for these programs. Another program that we have for pretrial is the jail diversion program, right? And that's something that we've had for 20 plus years. It's a collaboration that we do with the Department of Mental Health and Addiction Services, where they provide clinicians, right, to each of our GA courts that screen individuals that are in lockup to determine if we can develop an appropriate community release plan for that individual with behavioral health services in the community through either our ABH providers, our adult behavioral health providers, I'm sorry, that's ABH, adult behavioral health, or through the local mental health affiliates or other providers that provide mental health services in the community. It's an exceptional program. I'd like to thank Demus for their work on this. And, Senator Austin, I know that this is something that's important to you, being a member of the Sentencing Commission, and what you asked us to look into there about diverting as many people as we can from the Department of Correction, right, who have behavioral health needs that can be treated in the community. And this is just an example of a program that does just that. And I just want to thank Demus for their work that they do for us each day in the JA courts throughout the state. Next slide, please. We also have an ASSIST program, right? Advanced Supervision and Intervention Support Teams. And we do this in collaboration with the Department of Correction and the Department of Mental Health and Addiction Services. And this is for individuals with moderate to more serious mental health illness that, again, we can supervise in the community. We have contracted providers that deliver intensive clinical case management, psychiatric support services, medication management, mental health treatment. So it's really a comprehensive case management model for individuals with behavioral health needs that we provide. In 2021, we referred 237, and again, it's down significantly from pre-COVID, where we had close to 500 referrals for services, and we currently have this in 10 court locations, and I will discuss that later on in the presentation as opportunities for possible expansion and additional behavioral health services in the community. This is an excellent resource for the branch, for the judges. We see a lot of success in managing this caseload in our ASSIST programs. Our adult behavioral health contracted services network, we provide services for each of our GA court locations through these contracted providers. They are excellent partners in the work that we do in the branch and working with individuals with behavioral health issues, substance abuse issues, and they provide integrated substance use and mental health evaluations. They do individual counseling, they do group therapy, intensive outpatient treatment, medical evaluation and medication management. And again, you can see the number of referrals this past fiscal year and those that were referred pre-COVID. I'd also like to just, the medication management, one of the services that we built into this model in our last RFP cycle was for each of these providers to have medication assisted therapy as part of the menu of services that they provide to individuals that they serve. So each one of these programs provides some sort of medication assisted therapy. And then, another thing that we do in the branch that's not on this slide that I just want to talk about for pretrial services very quickly is our treatment pathway program. I mentioned it in the last slide that we'll get to, but that's a program that we currently have in 4 locations. And in 2022, we expect to expand that to an additional 4 locations for a total of 8. And this is a program where we can get individuals that have significant substance abuse issues into a treatment program, often a residential treatment program or a bed, right from arraignment. And it's very effective in treating substance use disorder, and we can accept referrals for individuals with lower behavioral health issues that don't need an enhanced level of care. Next slide, please. So now we're going to go over to the post-conviction side, and I just want to talk a little bit about how we identify mental health issues, behavioral health issues on the post-conviction side. We use what's called the level of service inventory here in the branch as our risk and need assessment classification instrument, which has an emotional personal domain, which identifies behavioral health issues. And in addition, we used what's called the adult substance use survey, which has a mood and disorder subscale that also helps us. And that will lead us to make referrals to the Adult Behavioral Health Network that I'll talk about in a minute. But that is what our probation officers primarily use to identify through our assessment process individuals that may have behavioral health issues. And again, we have specialized caseloads that supervise individuals with behavioral health issues. They're specially trained in how we deliver our services. Bill Halsey talked a little bit about the expedited screening process that DSS has with DOC. The branch also has an agreement with the Department of Social Services. We actually fund a position there that completes expedited benefit applications for those individuals that are sentenced to a period of probation. And we conduct that in the first office visit when they come in. And if they had their benefits expired for whatever reason, we can quickly and timely re-engage those services, or if the person is eligible, we can get their application completed and screened in expedited fashion to get them Medicaid eligible, which is very significant in our process, because part of that even gets to transportation of individuals from their home to treatment services. So that's a very important part of what we do. And I want to thank DSS for their collaboration with us on that particular project. Next slide, please. So a little bit about the mental health. We have specially trained adult probation officers with capped caseloads of 25 to 35 for individuals that have behavioral health issues. We provide enhanced supervision. And again, we collaborate closely with our contracted providers, our Adult Behavioral Health Network, and our local mental health affiliates to ensure that these individuals are getting the proper services and medication management that they require to be successful in the community. We have these officers in each of our offices throughout the state, and they do a very nice job of working with individuals with behavioral health issues. And we continue to work with the Department of Mental Health and Addiction Services and our contracted providers to provide training and collaboration with these officers to ensure that we're all working collectively to provide the best services to the individuals under this particular caseload. Next slide, please. And again, this just goes through the services that are available to probation officers, and it's the same services as we saw on the pretrial side, right? Our contracted services here in the branch are for all the clients that the courts serve. And I spoke about the assist programs, and I spoke about our adult behavioral health programs on the pretrial portion of this presentation. The only additional service on the post-conviction side is this multi-systemic therapy for emerging adults. This is a service that's available to young adults up to the age of 26, and this is an intensive in-home clinical-based services where clinicians go into the home and they work with individuals that have behavioral health issues and their families, right, as to the issues around what may be going on in the home and how they can best address that. So that's an additional services that we have on the post-conviction side. Next slide, please. So this is our residential and housing service network for individuals with behavioral health issues. We have the Sierra Center. It's a 23-bed residential program in New Haven that works with individuals with behavioral health issues. We can also use our contracted providers in addition to the services that they get at the Sierra Center to supplement the services that they do get while they're there at the Sierra Center. our Demus Collaborative, our residential treatment network of 167 beds that can accommodate individuals with co-occurring disorders. That's a very important resource that we have. And we placed many individuals out of the Department of Correction into our collaborative beds. And then our transitional housing network is a short-term 30 to 90-day staff secure housing network that we have that has case management. But again, we couple that with services that are alternative in the community programs, our adult behavioral health programs. Next slide, please. Okay, so this is the last slide, and you know, these are the things that we're working on, and we have been talking about with you all in the Appropriations Committee and our colleagues in our other state agencies. And I noted this in the juvenile presentation. All the providers that we're communicating and having conversations with now that we contract with are, again, short-staffed, having a hard time recruiting and retaining staff, retaining qualified licensed clinicians. And it really gets back to competitive wages, right? They're leaving for other opportunities in hospitals, private practice, rather than continuing to work for our behavioral health contractors. Peer support, recovery coaches, and our ABH contracts. This is a really effective component to treating substance use and behavioral health disorders. And we're hoping to make progress in the peer support recovery area of our business. Recovery houses, this is a resource that we could use as a step down from our residential treatment program. So somebody gets through a residential treatment program and they've you know, reached their appropriate level of care and they are ready to be discharged, but they're not quite ready to go home, right? And can we build upon our recovery house network that we have for individuals that require that type of step down? The assist program we talked about before, we currently have it in 10 court locations. It's about $125,000 per location to operate. This is a very important resource for us in the work that we do in the branch. And we believe it would require an additional 8 to 9 locations to be able to operationalize this service statewide. And as I previously mentioned, the treatment pathway program, we'll have 8 sites by July of 2022. We would need an additional 9 to have this service available in each court location throughout the state at approximately $160,000 per location. Transitional and rapid rehousing and the reach bed expansion. You know, we do a lot of work with the Department of Housing, with DSS around housing, and we appreciate the collaboration and cooperation with those agencies, you know, with the Department of Correction and with Demus. And we continue, we're ready to implement another rapid rehousing program in Hartford as we speak, as a result of some success that we've had, a lot of success that we've had with our pilot project in New Haven. And then lastly, you know, we think we're most likely going to have a need for additional transitional housing based upon the 1115 demonstration waiver that Bill Halsey mentioned briefly and he's in his presentation. So we're going to modify our procedures and how we place people into transitional housing before they get into a residential treatment program, which could cause a strain on our current transitional housing beds and the number of people that we can refer. So we're going to keep an eye on that as we roll out the 1115 demonstration waiver. So Madam Chair, that's a lot of information in a short period of time. And I know at the end, we're going to have questions, and I'll be happy to field any questions that anybody participating may have. So thank you.
Thank you very much. Up next, we have Commissioner Quiros from the Department of Corrections.
Good morning, Madam Chair and members of the Appropriations Committee. My name is Angel Quiros from Commissioner of the Department of Correction. With me presenting, I would have Tom Cosienda, who's the Director of the Behavior Management Service for the agency, and Dr. Craig Burns, who's the Chief Medical Health Service Officer. We're going to talk about 4 different areas. We're going to talk about the classifications of the offender population that are under my custody. We're going to talk about the number of individuals under my custody that are receiving mental health cares. We will also talk about the current challenges that we have in the Department of Corrections, in particular to the COVID pandemic. And then finally, we'll talk about the coordination with the mental health services on the returning citizens to the community in the discharging planning. That is my portion, and now we'll have the doctors go over the slides. Dr. Burns, Dr. Cosiendo?
I think Dr. Burns is muted still. I don't know. I can hear him in the other room. So,
Okay, Dr. Cosiendo, why don't you go right now?
sure. So good morning, everybody, and thank you for allowing us this opportunity. The first thing we'll talk about today is the classification of inmate mental health needs. There is a 5 classification hierarchy that we operate by, which is an assessment and treatment need process. Dr. Burns is sneaking in now. Our mental health level 5 services are acute care, which is emergent mental health treatment need, which is usually infirmary based.
I will take over from here. So again, the mental health files are people who are infirmary based. They are actively decompensated psychiatric illness and need of emergent care. Mental health 4 inmates are individuals who are still symptomatic, although they may no longer have issues of dangerousness that will keep them from being at least partially populated. They are usually in milieu-based outpatient mental health care dedicated areas, what we call mental health 4 housing. They are not quite ready for general population. Mental health 3s, which are essentially standard outpatient mental health care. They are general population persons in custody, and what they're usually doing is engaging in rehabilitation and mental health as a part of their day. Our mental health 2s are people who have history of mental health care. They may not actively be in care, but because of that history, we know that they can develop and increase service needs. So there is communication between our regular providers and that population that we take care of. And then our mental health 1s, individuals who have no history, no evidence of symptoms, and no need or no interest in mental health care. Turn it back to my colleague.
Next slide, please. Thank you. So what does all that mean in terms of a clinical presentation and service provision? For our mental health or acute care patients, this is considered an inpatient level of care. It's an infirmary setting. It has 24-hour nursing. It's got frequent and typically daily and multidisciplinary involvement with treatment, including psychiatry, psychology services, as well as master's prepared social work and professional counselors and rehab therapists. Typically, we also involve, if we have to have a rapid need for stabilization, we will engage in an involuntary medication panel hearing, which would allow folks to administer meds against will. The objective in this unit is to eliminate dangerousness to self or others, and to be able to hopefully improve psychiatrically enough where they can be reduced back down to either a mental health 4 or mental health 3 level of service need. Mental health 4 services in that environment or that housing environment, care is the daily focus. This is for folks that are engaged in daily group therapy work, weekly individual therapy and sessions, intensive psychopharmacological interventions and adjustments. The whole focus of this level of care, which is a milieu environment, is for further psychiatric stabilization and help determine what the overall level of functioning is for the individual from a psychosocial perspective within our correctional environment, and hopeful and likely improvement over time, and goal to reduce to outpatient services. For mental health level 3 services, as Dr. Burns had indicated, is our kind of our standard outpatient level of care. Rehabilitation is the focus, and mental health care is a part of that. Group and individual therapy treatment offerings are offered throughout the entire department in every correctional institution. There's medication management. Usually that's for folks that are already stable on their medications for routine visits that are typically about every 90 days at the outlier. The objective is to establish and enhance effective coping and internalization of mental health resources and improve overall resilience. Next slide, please. Okay, for our mental health 2 population, these are folks that it's a dynamic situation for the scoring. These are folks that have known past psychiatric histories and treatment episodes of care, both in the community and or within our correctional setting. Some of these individuals may actually need temporary higher service need provision, and we would assess and provide that service. Some of these folks also experience a crisis, and that would increase a temporary service need that we would provide the overall clinical care. The objective at this level of care is to maintain effective coping skills and manage any crises. And for our mental health 1 population, these are generally limited to no service, with the exception of acute crisis, occasional requests for treatment service due to psychosocial stressors or something that breaks from their norm. Okay, and our objective in those instances are to be available for both individual requests and or crisis moments. Next slide. Thank you. For that descriptor, this is our breakdown for the number of individuals that we have in our service provision for the acute care or inpatient level. This data was mined from the end of December. At that point in time, there were 52 individuals that were receiving acute care inpatient services, or about 1% of our overall population. For mental health 4, or our kind of milieu-based intensive mental health service, we had about 5% of our population that's actively involved in that level of service care, about 455 individuals who are incarcerated. For our general outpatient treatment, those receiving mental health 3 level services, that constitutes about 27% of our population, or about a little over 2,500 inmates. For our mental health service level 2, those folks that are incarcerated that are kind of in need episodically, or we keep on the radar to make sure that we are available should the need arise, comprise our largest demographic of 41%, or just over 3,800 people incarcerated. And for our folks that are in no need of treatment at this point in time, again, 27% of our population. I think the most significant piece of this data is that those folks that we are engaged in some form of treatment with comprises about 73% of our population in our correctional institutions. Next slide.
So there are some current challenges that we've been experiencing within DOC. One of the things that we know is that over the last couple of years, the actual number of people in need of psychiatric care has actually increased, therefore also increasing the percentage of people who need psychiatric care. And this is now escalating due to some COVID-related issues. I think that everyone is aware of what they call the dual pandemic of both COVID, but then also its impact on people who have histories of mental health. The increased stressors, the increased isolation, are things that are impacting everyone. But I think that the people who are seriously mentally ill are particularly vulnerable. There have been COVID-related impacts on DOC operations, and there are other people on the call who are operations focused. I am mental health, but one of the things that I can mention is that the increase in service requests has probably come as a function of the quarantines that we've had to engage in, both at the unit level and the facility level. The reduction in the availability of people being able to visit with families, family contact having potentially dropped off because people's families are ill, and then with respect to their court involvement, longer periods to resolve their court-related issues. Next slide, please. As we all know, mental health is very much a people-human connection dependent endeavor, and the people who we have providing that care internally are master's prepared clinicians, as well as doctoral prepared clinicians that will take time to develop. And when people are coming out of those kinds of programs, coming to corrections to provide psychiatric care is not, I think, top of mind for a lot of people. And as a function of that, we do struggle at times in recruiting psychiatrists and or mental health APRNs, although we are able to do it. It's with usually Herculean efforts to do so. The same is true for our psychologists and trying to get people to come into the system. One of the core issues is the overall compensation package and packages, which include salary and benefits for the job listings that we provide for folks who might be coming into our system. And right now they're below the current market level for private hospital and private sector employment. The issue is when you come into corrections, you are at greater personal risk in that setting. And that may be one of the reasons why people are unsure about coming in to provide care, although, day to day, it is generally a safe place to provide care for people.
Next slide, please. Some coordination and collaboration for folks that are returning citizens of the community. We have a regularly scheduled and meeting multi-agency reentry advisory group, which we refer to as Mirage. These are for high-risk individuals, both high risk from a mental health perspective for recidivism, but also regarding criminogenic behaviors. This meeting is a collaborative effort attended by DOC, usually Dr. Burns and myself, and discharge planners, Demus representation, DDS, adult probation, the VA, state police, and parole and community services all attend with the goal of helping to find durable and lasting returning pathways. Another collaborative effort that we are engaged in with Demus primarily is a high utilizer discharge meeting. This is a meeting that is co-chaired by DOC and Demus. And its main focus is to provide an opportunity for, again, durable discharge planning for specifically to address mental health, severe mental health issues, both from a treatment and social services perspective in terms of housing and in stable environments. Sometimes this involves the Board of Pardons and Paroles, adult probation, Demus clinicians, and LMHA contracted providers, and DDS involvement as well. We have regular Demus and DOC case conferences for returning individuals in custody to the community. These are for folks who have intensive mental health needs that we really have to do a lot of wraparound service provision for. Well in advance of a release to the community, we are engaged in case conferences to discuss needs, establish pathways for care and coordination of services. Lastly, one of the other things, we have regular petitions to probate for commitments, guardianships, and conservatorships to be able to support these transitions back to the community for those individuals that are significantly impaired. We do have some folks that have very little access to resources and support, and beyond our respective agencies, sometimes they need somebody to be able to provide that level of assistance. Next slide, please.
I would like to mention in the context of our coordinated care with our partners in the state, I'd like to thank Demus, now that I can, to do so for allowing us to participate in a federally funded grant for the expansion of telehealth. And there's some things within our system that have actually been helped a great deal by that. Our ability to conduct our involuntary medication panels across the state, as well as being able to connect people who have substance abuse issues with interviews with community providers to help with getting them out sooner. And lastly, this month, we'll begin to do competency evaluations using telehealth in order to help to expedite those being done, especially in the middle of COVID. We also have a lot of involvement with jail diversion and jail reentry. If we have someone who comes into us on a Friday evening who is psychiatrically decompensated and has remained Monday morning following, if they leave early on the court run, there may have not been a doctor level clinician to see them to actually provide an emergency certificate. Our discharge planners will call ahead to jail diversion to make them aware of that person in the court. And one of the candidates or people who they have there can actually evaluate that person to see whether they need inpatient hospitalization as opposed to going to the street. It also works in reverse in that our jail diversion colleagues will give us information about people who are coming in, who they may know, who may be high utilizers in the community, so that we have some sense as to important information like conservative contact, what meds they may have been on last, most recent hospitalization, so we can make sure that we hit the ground running with those individuals when they come to us, so we can maintain continuity of care. And I have to mention, the folks at the nexus of this are our dedicated master's prepared and licensed discharge planners who focus on providing transitional services for mental health 4s or mental health 5s and our mental health 3s in the system. And that's the last slide.
All right. Thank you both very much. Thank you, Commissioner. We have up next Commissioner Chef, Department of Developmental Services.
Good morning, Senator Austin and all your esteemed colleagues from the legislature. This is Jordan Sheff from the Department of Developmental Services. I have with me today Deputy Commissioner Peter Mason, my Chief Operating Officer Katie Rock Burns, legislative staff Kevin Bronson and Rod O'Connor, and I will turn it over shortly to Dr. Tolosano, the head of our psychological and behavioral services. We thank you for the opportunity to share the information today, and we'll be happy to take any questions at the end of the presentation. Dr. Tolosano, if you would, lead us through the slide deck.
Next slide, please. Thank you so much, everyone, for having us. Thank you so much, Jordan, for the introduction. We'd like to start off with providing a statutory definition of eligibility, which is quite different from the diagnostic manual definition of intellectual disability that folks might be familiar with who work in the clinical ranks. So the definition of eligibility, determination of eligibility, has three different elements to it. One is that we want to have a valid IQ score of 69 or below. The following slide is going to talk a bit more about the nuances of that. We also want to see deficits in adaptive behavior, so how an individual gets along in their environment as commensurate with their age developmentally. And then also, we want to see evidence of these first two components during a developmental period from birth to age 18. Next slide, please. So as I mentioned, there's a number of nuances here in terms of determining eligibility for our department. So we have an eligibility unit that is directed by a psychologist. And when we're doing eligibility determinations, we want to look at chronological history because it's quite important in terms of the onset of particular issues and putting things into context for us. We're also going to look at psychometric testing and so forth. As I mentioned, we want to have a valid full-scale score of 69 or below. And the reason why we put such an emphasis on the validity of that score is that oftentimes there are discrepancies between the subtests that are part of an IQ test or the indices, as you can see on the slide. There's a number of verbal and nonverbal indices that make up that IQ score. So if someone has a large disparity between those index scores that make up that full-scale test measure score, then the number may be misleading. So that's why it takes a more nuanced, sophisticated approach to understand what the IQ numbers mean. As I mentioned, we want to see adaptive deficits in functioning. Those need to be concurrent with the full-scale IQ below 69. Please remember that adaptive functioning is largely predicated on someone's cognitive functioning. So the lower the cognitive functioning goes, quite often the adaptive functioning goes with it. We have noted on the slide three different areas of adaptive functioning. And these are the classic ones as measured by something like the Vineland. We have practical skills like hygiene and self-care. We have conceptual abilities. The big one there is around finances and money, and which obviously requires some ability to abstract, to understand, and then social communication skills. The reason why this needs to be evidenced during the developmental period from birth to 18 is that there are other conditions that adults may experience, like acquired brain injury, traumatic brain injury, dementia, that present like intellectual disability, but they're not. They don't have that developmental component. So as I mentioned, that chronological history is super important. Next slide, please. So when we start looking more closely at behavioral and mental health issues in the context of ID, there's a couple of things we want to appreciate. First of all, that those with intellectual disability experience the full gamut of co-occurring psychiatric disorders, the same as individuals in the general population. However, the rates of cases, when you look at those with ID compared to the general population, is actually 3 to 6 times higher in terms of mental health diagnoses. So there's certainly a predisposition to psychiatric issues among our population. That's due to a variety of issues. Sometimes it's concomitant with a particular syndrome the person has, like Down syndrome. There could be genetic loading. There could also be things related to cognition, for example, like limited insight. One of the things that we talk a lot about in our department, and Commissioner Sheff has been really great bringing this to people's attention, is a phenomenon called diagnostic overshadowing bias. And this not only occurs in the realm of ID, this can happen in any format of mental health or healthcare is when clinicians overlook mental health signs and symptoms because there's ID in the picture, or they attribute all the mental health issues to the presence of intellectual disability, which is actually doing a disservice to our folks. One of the key things that we deal with as clinicians in our system is the under-recognition of mental health conditions, and that's oftentimes exacerbated by the systemic over-reliance on verbal communication to achieve a diagnosis. So as you can imagine, folks that we serve, especially those that are of lower functioning, they don't have expressive language skills. They don't have the ability to capture complexity in the symptoms that they're experiencing. And that could even go up to something called psychosocial masking. So an individual may try to conceal their deficits to appear appropriate, or oftentimes, in my experience, they're afraid of some type of consequence if they don't go along with things. So there's a lot of nuance, again, in this type of work. And then lastly on this slide, the importance of trauma-informed care. A conservative estimate is that among the individuals we serve, 70% of them will experience some type of aversive or abusive life event in their lifespans. That number is probably higher. Some estimates are in the 90% range. So we are, within our system, very much advocates for trauma-informed care. We want people to understand how trauma affects the mind, affects behavior, and so forth. I like to take it one step further. I like the term trauma-sensitive approach, meaning I like to inform people about trauma, but I also want them to act accordingly and not rekindle someone's trauma, which is like the next step of providing supports appropriately for someone. Next slide, please. So an overview of mental health services within DDS. So we have 3 regions across the state. We have supervising psychologists who are clinical directors in each state. So I have a group of 5 supervising psychologists in total, a wonderful group who's been super dedicated in a variety of ways, and they provide services across the spectrum. So it could be clinical consultation, it could be providing direct services, again, runs the gamut. One of the things that we've really prided ourselves on in recent years is something that's been in the works for about 20 years, which is, you see on the slide, the Programmatic Review Committee. And the Program Review Committee stemmed from the consent decree at the closure of the Mansfield Training School back in 1986. And what the PRC is an oversight committee, multidisciplinary, that reviews individuals in our system who receive psychiatric meds and also who receive any other kind of behavioral supports. So we have about 17,000 individuals we serve. About 1/3 of them are reviewed by PRC. It doesn't capture everybody. For example, somebody living in a family home who's their own guardian, who goes to their primary care physician for meds. We're not going to be able to oversee that per se unless they want oversight. But again, about 3,500 or so folks are reviewed by PRC. So all the medications that they take are reviewed, and everyone who is involved in PRC process has to have comprehensive care, meaning along with the meds, they have to have a behavioral support plan and oversight. What we've done, particularly in the last couple of years to bring this to fruition, is we have incentivized providers and prescribers to reduce intra and interclass polypharmacy. So polypharmacy, how it's defined, runs the gamut. In our system, it's 3 or fewer medications. Interclass would be meds in the same category, like 2 antidepressants. Interclass would be medications that are from 2 different categories. So a depressant, for example, antidepressant, for example, and an antipsychotic. So anytime that prescribers move below the number of 3, they have to come for less oversight. Anytime they include new medications or new aversives or things to the behavior plan above 3, we have more oversight. In our system with PRC, we actually moved to electronic submissions before the pandemic. So the timing was absolutely perfect, and it's expedited this process a lot, and we can get additional information quite easily. Also tied to our PRC processes, we've done a number of reiterations of our PRC policy, behavioral support policy. So we've woven right into the policy and procedure our expectations for clinical behavioral supports, especially behavior plans. And most recently, we've really specified measures for restraint prevention right into policy as well. And last slide, please. And lastly, in terms of DDS partnerships, We have, again, a spectrum of different things that we do. So some of the things that are on the board here, the pandemic obviously hindered a number of things we had going on, but just to give you a snapshot of some of the things. So we currently have a new collaboration with Demus. I'm currently working with Simi Whalen, Charles DK, and Dan Brockett on a residential pilot to serve individuals with mental health and intellectual disability. We've done case collaboration in terms of hospital settings, outpatient, where our folks may receive care from LMHAs, but this is the first time in earnest in my 9 years in this position that we've done something residentially at this level. Myself personally, I do a large psychotropic medication. It's a 2-3 hour block of time in terms of helping folks to understand psychiatric medication prescribing, how to seek out consultation, and so forth. The idea is to make everyone on our system good consumers of behavioral plans, good consumers of psychiatric prescribing, so everybody's involved, for lack of a better term, in terms of policing those kind of things. As I noted on the slide, I have the Connecticut Women's Consortium. I'm presenting at outside agencies again, and that's coming up in March. Jen Crum from Beacon Health Options, and I do a positive behavioral support training for police officers in the area of special populations, namely autism. So we're hoping to resume that. We just redid our credential. And then also we do a lot of, as Tom Cosienda and Craig Burns indicated, we do a lot of interagency collaboration with the Department of Corrections. As I noted on the slide, interagency collaboration with Department of Corrections and Office of Forensic Evaluation on the topic of competency to stand trial restoration. In our system, though we don't have an abundance of cases with that, those are some of our most challenging, because the restoration process for ID is actually, in my opinion, a misnomer. It's actually, we're trying to create competency in folks who are unable to go through the process initially. I hope the presentation helps, and feel free to ask any questions. Thank you again for having us.
Thank you very much, Doctor. And now we have our last presentation, which is Kelly Valaris for the workforce strategy. Kelly?
Thank you, Senator Austin and the rest of the legislators. I appreciate the opportunity. We go to the next slide, please. The Office of Workforce Strategy has been working in partnership with other state agencies and the hospital systems across the state of Connecticut to address some of the pre-existing workforce shortages in mental health and nursing that have been exacerbated by COVID. So we've already had a shortage of registered nurses prior to COVID, but COVID-19 has increased demand by over 100%. The length of the mental health and nursing programs, which are typically 4-year baccalaureate programs, do make it challenging to address the immediate needs of this crisis. And I'll share with you a few things of what we are going to be doing. And the problem is getting worse as workers are leaving their jobs with burnout, mandated scheduling, and other factors. We had a conversation yesterday with the Connecticut Hospital Association, delineating some of those ideas and problems and how to address them. The career pathways to get into mental health and to nursing are typically expensive 4-year degree programs and often preclude our underserved populations. So when we look at nursing and mental health, we have a lot of people of color, people of color who are in the entry-level positions, but many of those do not advance through the career ladder into the higher certified and degreed programs. And that there's also a critical shortage of faculty to teach these programs across the state of Connecticut. And then I do want to also reference the issues with regards to compensation for mental health workers being below what the private sector pay ranges are, which exacerbates the issue of people not getting into mental health careers. So the next slide, please. And we're looking to address 2 different gaps in mental health. The first is that we don't have students enrolling in mental health educational programs at the rate that matches the demand. And there's 2 proposed solutions here. One is to work directly with employers to provide incentives for mental health professionals to relocate to Connecticut, so bringing in talent from outside of the state. There are some barriers to that, in that our employers must be willing to provide additional funding to incentivize individuals to come to the state of Connecticut. And also some of the keys to success are determining whether the state can offer matching funds to employers to incentivize their participation. This was a point that was also emphasized yesterday with the Hospital Association, and understanding where the dollars and funds would be for these costs, and knowing that they only have a certain amount of funds that they're allowed through their insurance agencies to be able to pay people in mental health and other healthcare related workforces. So another proposed solution to addressing this gap of not having enough students enrolled is to develop alternative post-secondary pathways for individuals to earn degrees in these fields. So working with the four-year institutions on accelerated bachelor's programs and apprentice programs are two examples of trying to get students into these professions sooner than those 4 and 6-year degrees are required. And some of the barriers are determining the level of effort this would take for educational institutions to accelerate these programs. We have had conversations with UConn and several private institutions around the state who are more than willing to work on developing these accelerated programs for mental health and for nursing. And some of the keys to success, as I mentioned, is engaging these educational institutions and also researching what is being done outside of the state of Connecticut that could serve as a model. And again, there's additional costs associated to this. And so where does that funding come from? The second gap that we're working on is that most occupations, again, rely on expensive 4-year degrees. And there's not an immediate demand that must be filled. So there is an immediate demand, that must be filled. But how do we help people who can't afford to get into these programs the ability to do that? And so looking at offering scholarship programs, maybe through the state scholarship funds, to provide incentives for students to go into these programs by forgiving certain parts of the loan if they take these degree programs and stay in the state of Connecticut. And that's something that the Office of Higher Ed and our office have been discussing, and there's a lot of interest around developing these types of scholarships, and also identifying students who are who hold associate or appropriate degrees that relate to professional mental health, but don't necessarily have a licensure to practice. And how can we identify those individuals and bring them back into the profession and get them those certifications that they need in an accelerated fashion? So again, making sure that we're providing the amount of incentives for individuals to come back into the mental health career pathways is something that needs to be determined. And then where are, again, the funds to develop these incentivized tuition reimbursement programs and mechanisms for recruiting individuals into accelerated programs. So the next slide, please. And as we know, the Office of Workforce Strategy has been authorized $70 million of ARPA funds. Those funds were allocated and authorized specifically to address short-term training programs to get people back to work quickly. And we are allocating a significant amount of funds to the healthcare professions, entry-level professions, and trying to address some of the short-term and longer-term nursing shortages that also really relate strongly to the mental health profession. So if we look at people such as CNAs and community health workers and nurses, a lot of times they could be the first point of contact with a patient that has a mental health need and could be the reference point to referring them into mental health programs, as they had been explained earlier in this presentation. So really looking at how we can utilize funding to address those short-term gaps. So we're looking now that there's over 7,000 qualified nursing students that apply for nursing programs each year, but are denied because of the shortage of faculty to teach those programs and the shortage of clinical time to gain their licensing permits as required. So the general statute allows for temporary or permanent waivers, removing requirements that nursing faculty need to have advanced degrees. Those waivers have been applied in several cases in Connecticut and other states and have had a good success rate on bringing more faculty into being able to teach in higher institutions, not only the associate degrees, but the advanced degree programs. So we're also looking at some additional proposed solutions here, and they are to survey, and some of this is in process now, to survey schools to determine the current and forecasted faculty and what would be needed to address the growing size of the nursing workforce. Also looking to utilize the Connecticut's licensing system to recruit retired nurses as part-time faculty and for teaching in the clinical prep courses. Looking to develop a statewide marketing campaign for nursing faculty and for nursing students that can come into the profession and pick up some of the slack that's needed there. And to develop a pilot program where individuals who've earned 9 credits in their nursing master's degree programs could be hired to teach while finishing their graduate degree programs. And these are all ways in which we could address the immediate needs for the nursing shortage. And again, a lot of these professions in nursing can roll up the career ladder into those mental health professions. We're also looking that, the pandemic has increased the demand for nurses in the state of Connecticut. And that, again, that those nursing degrees are typically 2- and 4-year degrees or 6-year degrees. And that only 8%, about 484 students, are enrolled in RN education programs that are accelerated. And only 34% of students enrolled are in associate degree programs. So that's looking at the fact that we really don't have a very robust accelerated program that we need to build out. And conversations, again, with our 4-year institutions and our community colleges have been very responsive about developing accelerated programs into these needs. And so some of these programs allow someone to become an RN in a 12 to 15 month period of time if they have a bachelor's degree with a related topic, with a related degree. We also looking at how we can partner with employers to developing hiring practices that focus on 2-year degrees to alleviate the short-term needs while giving those workers the flexibility to continue to work and go to school at the same time. Similar to setting up apprenticeship programs, the Department of Labor has a $10 million grant that they're working on with Yale University on those types of nursing apprenticeship programs, and they work very well. So how do we get more people into those programs so we can get people working faster? And then competitive salaries for entry-level positions. So the salaries really are minimum wage salaries. And a lot of times we get people into these entry-level positions and we don't have the time or investment spent into them to upskill them to the next level and have stackable credentials so someone can go from a CNA, take their credentials and their experience and roll that to an LPN and then roll that to an RN. And then again, looking at the related mental health pathway programs, doing something similar there. And then looking at how we could explore benefits cliffs relief for these entry-level workers. So a lot of times someone will come into the profession at an entry level and they are reluctant to advance in their career ladder and earn more money and advance certifications because they lose all of their benefits, which isn't made up for by the smaller incremental increase in their salaries. So looking at ways in which we can provide some support to ensure that we can upskill people and have them weaned off of the benefits, not just a cliff. So these are some potential solutions to these problems that we have been working on with our state agency partners and our healthcare partners regarding the benefits for nursing. And that concludes my presentation. Thank you.
I think that concludes not only yours, but all of the presentations. So thank you very much. If you could take down the slide deck, that would be great. And for all of you on the call, the slide deck was sent out earlier today. So you have that. And Senator Minor has been listening in. He has poor reception where he is. Unlike Representative Kennedy, he is not in 85-degree weather. So just so you know, he is paying attention to what we have going on. He's out in Colorado. So I'm going to start out with a couple of questions. And my questions, I'm not certain which agency it would go to, but and we'll try to exist with 2 questions per person to start out with. And that is looking at the budgets that were presented and the talk that everybody had about federal dollars coming in. Do all federal dollars that come in travel through the Office of Policy and Management, or do they go directly to the agency that requested them? Does anybody know that, or is it kind of like a?
So this is Interim Commissioner Navarrete. I can answer generally. Oftentimes Demus will apply for federal funds and they will come to Demus, but every contract has to be approved by OPM. So they are aware of all the dollars that are coming in and going out to providers across the state.
Thank you, Commissioner. Judge Carroll, is that the same thing for Judish?
No, my experience has been we don't get any federal funds but through OPM. And often, Senator Austin, as you know, we have shared with you and members of the Appropriation Committee requests that we have made of OPM for federal funding. That's where we stand. If Gary's on the line, if his experience has been different, please let us know. But my experience from the very beginning is that everything must go through OPM first.
Would that be true of VOCA funds for those of you who might be asking me, which is what does VOCA mean? The Victims of Crime Act, the federal dollars. Does that go to you, or does that go to the providers?
My understanding is that we do make direct requests for VOCA funding and have done so in the past. I'm not sure, Senator Austin. I can double check to find out whether that funding goes through OPM first. I know that there are individuals designated within OPM who handle those grant requests, but I'm not sure the extent to which our requests are scrutinized by them prior to any grant award directly to the judicial branch. I'll find out.
Thank you very much. Gary, did you want to add anything to that? I know you took yourself off mute.
Yeah, thank you, Senator Austin. No, I was just going to agree with Judge Carroll. Any of the ARPA or CRF money is all come through OPM.
And do you get other federal dollars besides CRF and ARPA?
Grant dollars only. Well, other than the VOCA money that Judge Carroll was just speaking of, CSSD within the branch, just grant dollars for various projects.
And would they be, I don't mean to be obtuse, but I'm trying to make sure I understand this. Would that money be directly for a program, a specific program? Would we know about that? Would go through OPM, or do you sign a contract that, because you are a different branch of government. So do you sign those contracts directly?
Yes,
we do.
Okay, great.
Yes.
I just wanted to understand how we were doing that. I might have some additional questions relative to that. My second question is for Kelly Blaris. Kelly, I know we put in the budget $70 million of ARPA dollars for workforce development. But I know that you're keeping $8 million aside for administrative on other issues. So it's not really $70 million going out to those courses. And I appreciate the fact that you concentrated on the nurses. Representative Walker and I had been putting money in each year over the last 3 or 4 years for training for people in the healthcare field. But there were a couple of different other areas that I was hoping that I would hear about, and that was relative to mental health, job classifications, and then job classifications for people who are using the mental health services, that are adults using the mental health services. Are you looking at job classes relative to, and seeing as we have this additional $8 million, are you looking at job classes relative to some of the other job classes that the different presenters say that they are short of? And are you looking at jobs that people who are using the services that may be able to take some of the jobs? So those would be my questions relative to the workforce development component of it. And up next will be Representative Walker, followed by Representative Dillon.
Thank you for that question. With regards to the budget, $2 million is going directly to DOL to support their summer programs, as was required through legislation. And we also have funding put aside to develop a marketing campaign to ensure that everyone who is interested in job training programs knows how to enroll through a single portal for all programs, so a one door into all programs. And we also have some funding set aside for the computer technology to support the intake portal and the reporting portal. With regards to job classifications, we've been working closely with the different state agencies and hospital and healthcare associations. Our primary focus has been on the nursing and related technical shortages, but we are more than happy to continue the conversation with our state agencies and expand those pathway programs as they relate to entry level in mental health. I know I've spoke with Commissioner Sheff multiple times about supporting his needs in his department, and through some of the programs that we have already determined through like a CNA and other types of personal care givers. Those are things that are going to be included in the programming that we do, and I will follow up with him and our other state agencies.
And just so everybody knows, Kelly has to go to another meeting at noon. So when she pops off, members of her staff will be here to answer questions relative to this issue. Representative Walker, followed by Representative Dillon.
Thank you, Madam Chair. And I want to thank all the commissioners and all the teams here today for your presentation. I'm gonna, Kelly, you're leaving, but I got some, okay, I can always call you, but first of all, I want to thank everybody for sharing what their needs are too, because that really helps us to look at this on a more global perspective than just trying to do dollar by dollar. And I thank you for that. Commissioner Gifford, you talked about, or I think it was you or somebody in your team talked about mobile crisis enhancement dollars that will be effective as of April 1st. Now, is that mobile crisis enhancement dollars for the state? But I know that a lot of towns have created their own mobile crisis and area programs in their towns to try and address some of the needs. Will they be able to tap into that, or does it have to come through DSS in order for them to get the enhancement dollars?
Thank you, Representative. That refers specifically to enhanced Medicaid match for mobile crisis services. So it would pertain to any service provided in any town to a Medicaid beneficiary for which the Medicaid program is billed for the service. So, my mantra is always, if there's a Medicaid covered benefit, we should be covering it through Medicaid, and that way we get the federal match. And as of April, as you correctly know, we will get even an enhanced match, and Bill probably knows the exact percentage on mobile crisis services. So we're very much working with DCF and Demus to expand those and make sure we have 24/7 statewide access to mobile crisis.
Okay, so just to follow up on that, so that means because I know my city has put together a mobile crisis team that is being led by Clifford Beers. So they would then come through DSS if we wanted enhancement dollars on that?
So I think, let me give a high level response and then I'll turn to Commissioner Navarrete and Bill. If they are enrolled as a Medicaid provider, and it's a Medicaid covered service, then they could bill Medicaid for that service. Now, I don't know if they are, and I don't know how it interlays with the DCF and Demus contracts for mobile crisis services. Sounds like it may be independent of those programs. But if they want, they wouldn't necessarily see the enhanced funding representative because that, that's an enhanced match that comes to the state. So Bill, do you want to comment on mobile crisis as a covered benefit in Medicaid?
Sure. And then certainly DCF and Demus can jump in. Demus is on the line. So Clifford Beers, for example, is a contracted emergency mobile psych service provider contracted with DCF. And on the child side, we are already billing and claiming for some of the mobile crisis work on the child side. So that example would be included. So they would have to be contracted with the statutory authority, DCF or Demus, and enrolled in Medicaid, as Commissioner Gifford said. And then that would be eligible for the state would be eligible for the enhanced match.
Commissioner, go ahead. I'm sorry. Go ahead.
That's okay. So I'll just add from the adult point of view that many of the municipalities, as you spoke, I know New Haven is working on a civilian crisis response, which is a little bit different from our mobile crisis teams that we have across the state. But what we've tried to do is work closely with any municipality that is bringing something like this up, so that there will not be a duplication of services and that there's a protocol of who would handle which calls. I think the New Haven calls are going through 911 and then diverted through 911 to a civilian response, which is a little different from access to the Demus mobile crisis.
Is there such thing as an adult mobile crisis system?
Yep, we have 18 teams across the state, covering every town. And we're close to 24/7, but we're not quite there yet in terms of deployment. We have 24/7 telephonic ability to respond telephonically. But that's the 2.5 that you put in the budget. Those are the dollars that we're putting toward getting closer and closer to 24/7 deployment.
Okay. Thank you. Thank you for that. And my final question, I know I'm stretching it, represent a senator, but is there a committee or an organization that has all of you on the same board so that once a month we get together and we talk about behavioral health in a variety of ways, so that we can look at quality assurance, so that we can look at the whole plethora of things that you all mentioned today, to see that we are all going in a positive direction? Because I don't see it. And I know behavioral health partnership is there, but I don't think all of you are on that. So I'm trying to understand, because I think we desperately need one team or one voice that's for mental health in a variety of ways. So Commissioner.
Yeah, I believe that CSSD and DOC are now attending the Behavioral Health Oversight Council Committee meeting. So they are at the table. Bill, correct me if I'm wrong, but I believe everyone is on.
Judicial branch definitely comes on a regular basis. I'm just trying to remember if DOC is a regular attendee at that meeting.
Okay. Well, I mean, I would really be interested in that, because I think for us, for the state of Connecticut, we got to have less separate organizations and meetings and committees, and more universal that engulf everybody in there, so that we make sure that we have a continuum of services and we're not having frequent flyers. And I don't mean to use that so loosely, but people that go through system after system after system, and it never seems to come up with a platform of really addressing it. So thank you, Senator Austin. I'll come back to the end of the line. Thank you.
Representative Dillon, followed by Representative Nolan.
Thank you very much, Senator Austin. And I want to thank the chairs for a comprehensive group of presenters. And I'll say that before I say I wish DCF at our last, at a recent meeting, I had asked how many of the children in Connecticut had suffered a loss of a caregiver to COVID, and the Commissioner of DCF added, or how many children are affected by a parent who's addicted to opioids. And that wasn't where I was going at that moment, but she's absolutely right. And I just wanted to add that little thing. It's not a question. It's just an editorial request to make it a longer meeting. But no, I think that the role they play is very important. I'm going to follow up on Representative Walker's concerns about workforce, knowing that I guess that Kelly's leaving. And I was part of the budgets that went down in the past 10 years, so that there are some things that I'm implicated in and some things that were done over my head. But I'm looking at workforce issues, and I'm really reassured to hear that you're working on nursing, but that's important to the hospitals for their accreditation, but for the rest of us in terms of community needs, that includes psychiatrists, social workers, many others. And it looks to me like everyone is chasing the same few people. And yet I keep seeing budgets that cut back on the personal services for clinicians. I guess I want to ask workforce strategy, because I think it is good you're doing nurses, but as I said, that's what the hospitals are going to be thinking about. Could we get a bigger strategy for attracting and retaining some clinicians to serve people across departments? And that, I mean, we have a need in Demus, we're down positions. The corrections presentation was shocking to me, and I haven't fully digested it yet, so I will go back and look at it after today, after this meeting. Could we put together a bigger list than just nursing?
Yes, we can absolutely do that. And we are looking at, nursing as being one of the foundation areas that we're looking at because of the crisis mode that the healthcare system is in right now. But we're also working to train community health workers, phlebotomists, personal care assistants. There's a few others, and process sterile technicians and pharmacy techs and things like that. But we can most definitely have broader conversations with our partners on the call here today. I'm working on those other career paths as we talk to the higher level associate and baccalaureate and master's degree programs that are required to get people into those mental health fields at a higher level. That really where the crisis is in the mental health area right now. That is in addition to the work that we're doing with the CARES Act dollars and the ARPA dollars, it's addition to. So we do work on multiple programs and at the same time. And so trying to address the short-term needs and then also working with our partners to address the longer-term needs is something we most definitely will be doing.
Thank you. And I don't want to put everything on you. I mean, it's just that it's your department, but I see budgets and I'm trying to tease out what on earth the people are thinking who put them together. If we're down positions because nobody wants to work for the state, and then you shortchange the private providers, and you cut Connecticut Mental Health Center, for example, and Hispanic Health. Well, if you're cutting the privates and you're not funding the public, I don't get who they think is going to see these people. It doesn't make sense to me unless they're just not dealing with it. So I'm putting it all in your lap, and it's not fair to you, but that's the name of your agency. So
Well, I will say that unfortunately, our agency has nothing to do with any of those items in budget that you just mentioned, and we don't have a reach into that. Maybe some of the other state agencies have more insight into that. And we're also have only been in existence for a little over a year, so we don't have the historical knowledge to really be able to fully see the long-term effects of this, although we're working hard to get up to speed.
thank you very much. And the Commissioner Gifford, I wonder if you could provide to the committee later potential ideas for prevention, and in particular prevention of hospitalization, because there was a program of psychiatric nurses that used to go out to homes of people with complex medical conditions, and it was funded on private and public, but DSS actually cut their rates and closed a program actually in I think it's in my district, your Representative Conlarius, which was because it was Medicaid only, because most of these agents, they cannot survive on Medicaid rates. I'm really curious if what kinds of strategies are possible, because we've placed these people in the community.
Representative, excellent points. We do have a number of strategies that we use aimed at preventing hospitalization. It's a really key part of quality measurement in behavioral health. I would point to the fact that we measure follow-up after hospitalization for mental illness as one of our key Medicaid measures. And it's because it's been demonstrated that appropriate follow-up for people hospitalized with a primary mental health diagnosis is key to preventing relapse and rehospitalization. We also just approved home-based mental health services in one of our waiver programs that came before the legislature. Bill can help me with the specifics on which specific waiver that is. And then, of course, I mentioned our early childhood interventions that we're very focused on working on with DCF and OEC, which are really upstream prevention, but which we think are really critical to the long-term prevention and sustaining healthy mental and behavioral health for the population.
Thank you very much. Thank you, Madam Chair.
Thank you very much, Representative Dillon. Representative Nolan, followed by Representative France. But I do want to put a quick footnote in on this. When we looked at the numbers of people that were having behavioral health issues, was around 500,000 people, give or take, and about 100 million, give or take about 20%, we were handling through the state-funded programs. It seems to me that in that other 400,000, again, I don't have the exact numbers, are going through private insurance in many cases, and they are experiencing a lot of wait lists relative to people that cannot get in to see a psychiatrist, a psychologist, or a social worker, because those positions are not being filled. So that's another area where we have a number of positions that need to be filled. Representative Nolan, followed by Representative France.
Well, Senator Austin, thank you very much, because that was actually going to be one of my questions, the numbers in regards to those that we're covering and those that might be drifting off to private insurers. So thank you for that. But I wanted to just tap on the integrated care for co-occurring conditions. How are we putting that out to residents? or those in the community to have an understanding that that is something that is available or that's going on. Because I've heard about it just a little. I haven't heard a lot about it, but there are a lot of, I think, people in our communities that would like to hear a lot more about that. So I'd be interested in doing some outreach on that to try and help put it out there. So if someone could maybe contact me in regards to trying to do something to further that and to find out a little bit more about it, I'd appreciate that, Commissioner.
Absolutely.
And the other thing was, I also agree with the conversation in regards to workforce, especially when you talked about maybe the phlebotomists and technicians being in addition to getting more attention so that we can try and fill a lot more jobs in regards to that. And the last thing would be transitional housing. Gary, I know you touched on that a little bit. Can you connect us with somebody to further talk about transitional housing? It seems like I'm hearing a few people that are struggling with that up in the southeastern Connecticut area. So I'd be interested in researching that a little bit more and trying to help out.
Absolutely. Thank you, Rep. Nolan.
Thank you.
And Representative Nolan, good morning. If I can quickly respond to your inquiry about co-occurring conditions.
Yes, Judge.
When we get individuals involved in the criminal justice system, one of the first things we do is screen them for co-occurring conditions. And many of the folks who are in the criminal justice systems are dual diagnosed with mental illness issues and substance abuse issues. But consistent with a concern that Senator Austin has made for years now, this is not the place where we should be making those diagnoses once folks end up at the end of the trail in the criminal justice system. So I guess the challenge is to try to find ways to identify these issues before they come to the criminal justice agencies, because that although we have resources available within the court systems to deal with those, it's probably not the most effective, most efficient way to deal with them. Our goal is to keep people out of the criminal justice system, not to bring them in so they can get treatment.
Oh, yeah, I agree. That's important.
Okay, take care.
All right, thank you very much, Madam Chair, and I appreciate all the dialogue because it was real important, and it's something that I think that the community needs to hear more about, so I appreciate it.
Thank you, Representative Nolan. Representative France, followed by Representative Johnson.
Thank you, Madam Chair. And question for Judicial Branch. Your presentation, you indicated a reduction in the demands for behavioral health services compared to pre-COVID. And given what we heard were the challenges of having cases move through Judicial Branch during COVID, is there a backlog that could present a potential spike in demand for behavioral service in the short term? And if so, is there a potential for budget impact if we anticipate that is the case?
Representative France, let me respond before I hand it over to Gary. I can tell you this, I was on the phone this morning with the Chief State's Attorneys and we were talking about pending inventories in our criminal cases. And I noted to him that it's significant to note that our incoming cases in the criminal courts is currently well below pre-pandemic levels. The rate at which we are processing those cases and disposing of them is now at the same level as they were pre-pandemic. So we've done a good job of trying to attack the pending inventory of criminal cases. With respect to treatment resources and treatment needs, Gary, I'll let you respond to Representative Francis' question if you can add some more detail to that.
I will. Thank you, Judge Carroll. So Representative France, as Judge Carroll noted, we're starting to see an increase in the number of cases that are coming into probation as part of a sentence. So that part of the system is now caught up to itself and is actually increasing, right? So we're going to see our numbers go back up there to pre-pandemic. I don't know on the arrest side for like the lockup arraignments that we were talking about. That's a function of, you know, as you know, how many people the police are arresting and how many individuals are coming through lockup for arraignment. So, but to answer your question, no, if we return to pre-pandemic levels, I think we're comfortable with our funding sources right now to be able to support that. And we've actually put positions in each of the contracts that we have to make sure that we maximize insurance benefits before we go to our branch funding as a payer of last resort. But thank you for that question.
Thank you very much. The second question I think will be for Demus. It's looking at the trend of behavioral health demands related to COVID and the isolation and other things that seem to significantly increase, particularly in our young people, young adults. Are there different processes, I guess, to identify solutions, or is it simply an increased caseload given the isolation, which seems to be one of the driving factors for this? Are there different techniques? Are we looking at potential different protocols that need to be done? And what are we looking at in order to deal with the outflow as we come out of the pandemic and the demand for behavioral health services that were driven by a different societal situation, principally by isolation and other things related to COVID directly?
I think it's the same type of services that already exist, mostly probably at the outpatient level of care. And as I showed in one of the earlier slides in the presentation, that's not just the Demus system of care, which serves uninsured and folks with SMI and serious substance use disorder, but it's also the clinics, the FQHCs, the non-Demus funding that or non-Demus clinics that are out there that see people, whether they have Medicaid, they have commercial insurance, they may be going through an adjustment related to work or home life situation or lack of work. So all of those are probably access to our outpatient, which then may loop back to our workforce shortage issue.
Okay, so I guess to summarize, it's not a different process of handling the issues that are before us in behavioral health. It would intersect with the question related to capacity to handle the increased demand, as opposed to different protocols or different processes to deal with the people who need the behavioral health services. Is that summarized?
Very correct.
Okay, great. Thank you very much. Thank you, Madam Chair.
Thank you very much. Representative Johnson, followed by Representative Terziak.
Thank you, Madam Chair, and thank you so much for all the amazing presentations we heard this morning. I guess to try and boil this down to some of the one of the main issues in my district and all the cross references to the potential for homelessness that have been probably not spelled out in the presentations. I do feel very strongly. Let me just say, I have a no freeze homeless shelter, and people are camped out on the river during the other months from that are between April and November, and then they try to get into the homeless shelter here for the no freeze. I have a Holy Family shelter here with numerous women and children. It's always filled to capacity, and that's no exception at this point in time. I just was there a couple of weeks ago. I also have a domestic violence shelter here. I have only 25,000 people in this town. We have some of the lowest income people in the state, and we are trying very hard and desperately to address the issues of the homeless, which brings me to my questions for all the different agencies. One is for the homeless people who are in any of these shelters, getting them into housing, of course, is something that we want to try and make sure that we do. And there are numerous attempts to get people into housing. But the follow-up question that I wonder about is how are we able to help them with payment of rent? If they are not going to actually be eligible for the Section 8, and when we look at the state assisted general assistance program that gives $219 a month to people, how would that pay for the situation where they would perhaps fund a place to live? And then how much of the trauma that is suffered by children who are in homeless shelters because for whatever reason they are no longer in housing, how many of those people are getting the kinds of mental health services that they should be receiving? And this is true also for the traumatic occurrences that occur if somebody's in foster care. But then we also run into a situation where we may be finding that we're creating a situation for students that are in the homeless shelter, say in the Holy Family Shelter, where they are getting the post-traumatic stress disorder, not able to finish their education, and then finding themselves in a situation with the criminal justice system. And I wonder if we're tracking those situations. And I'm just looking forward to hearing from people about that. And then also when people are discharged from the prison system, it's my understanding at this point still, are they getting all the—
Representative Johnson, can we ask a question?
Okay, well, a question would be,
questions. What is your question?
My question is,
I want to get a question answered for you. So
thank you so much, Senator. I appreciate that. My question is looking at spanning all the presentations we had today. How are we addressing the homeless issue in those circumstances?
Thank you. Who would like to look at that component of it? Commissioner Gifford?
I can offer just briefly that Connecticut through Husky has established recently a program called CHESS, which is designed for people who have a chronic illness and are high utilizers of the healthcare system. And it supports a comprehensive set of wraparound services, and it's paired with funding that the legislature approved for housing vouchers. So it's aimed, Representative, specifically at the type of population you're describing, which is people who are chronic high utilizers, need supportive wraparound services, and need support for their housing costs. I believe we have funding for 150 or 250 participants per year. Bill, is that the correct number in CHESS?
Yep. And we can certainly get that information to you, Representative Johnson. I think it was in a MAPOC presentation a couple of months ago, but we can certainly recirculate that program.
May I say that I am fully aware of the CHESS program, and it does not address the situations I'm speaking of. But thank you so much for that. I've been thrilled that the state of Connecticut has taken on CHESS. I know that this was a presentation that was issued at the Milbank Foundation, and it was one of the programs that was started in the state of Arizona 4 or 5 years ago. And I'm so thrilled that we were able to do that. So I'm really familiar with that program. I'm concerned, though, that if you're not utilizing healthcare services that cost the state more than $40,000 a year, which I think was the last number I heard under the CHESS program, that people that are not utilizing that kind of needed that kind of care are not receiving the kinds of support that they could use to make sure that they can fully be integrated back into our society. And so if you're a child growing up in a homeless shelter, that's going to be a different situation than someone who is in the CHESS program. So, but thank you for that. And I look forward to trying to hear how we're going to take care of the prisoners who are released without any services, without the kinds of identification that they need, that are in the homeless shelters here and living out in my river. So they're not maybe getting the kind of healthcare services that we need, but we're not addressing homelessness to the extent that I believe we should, and or to the same extent that we used to address it back in the 1990s when we had a better situation with the state assisted general assistance. So because we don't have those kinds of programs now, we have a huge number of homeless people, and I have a lot of them in my district. And I'm sorry to belabor this with everyone, but when you're a community of 25,000 people with 3 homeless shelters, it's got to be something that I try to do something about. So thank you so much.
Sorry, anybody have any comments on Representative Johnson's last statement?
Yes, this is Commissioner Kiros from Department of Corrections. I can tell you we're averaging anywhere between 25 to 35 EOS individuals are discharging at the end of the sentence that are homeless that we work with a discharge planner. They are identified when they come in as homelessness, and we start working with them at 120-day mark before they discharge. Since the pandemic started, we have paired up with the Coalition to End Homelessness and found these individuals housing, not in shelters. I will tell you that in the midst of the pandemic, we've had discharged individuals, and my staff have personally has taken them to hotels, and we've provided with the rental expense, working with the coalition. We also have about 135 apartments that we utilize for parole and community services that are called rapid housing. And we have used during the pandemic some of those apartments for the individuals that we recognize as homelessness. There's a percentage of the population that do come out with without identification, and makes it harder for them to apply for the services. And because they're convicted with a felony too, it makes them even harder to become eligible for some housing assistance in our communities. So we're trying the best as we can not to discharge these offenders into homeless shelters throughout the communities.
Representative Johnson, does that give you a couple of other things, couple of other tools in the toolbox?
Well, thank you so much, Senator. I really appreciate it. I do hope that our students who are homeless are getting the mental health services that and it seems like they might be, because most of them are in the Husky program. But it is a big concern, and the capacity for them to do well in our school system is also limited. So I'm hopeful that we'll be able to expand services to stop the homeless situation all over the state. Thank you so much, Senator.
Representative Terziak, followed by Representative McCarty.
But thank you very much. I had trouble unmuting it. Mostly I have a comment on the discussion of workforce development. We repeatedly talked about professionals and bachelor's and advanced degrees, and pretty much until the last couple minutes, ignored the fact that it's the exact same nursing license, whether you've got an associate degree in nursing or a bachelor's degree in nursing.
Peter, you're fading in and out, Peter.
It's a lousy connection. Lucky for you guys, I'm fading in and out. I'd like to see more attention to associate degree nurses, and let's talk about having paid internships. A million years ago, when I went to nursing school, back when we used to write our notes with charcoal on shovels, the Department of Mental Health and Addiction Services was doing a really good job at recruiting their own employees, helping them go to nursing school, scheduling classes that were held at workplaces when they could gather enough people together to take them. We need to be doing stuff like that. And by the way, that stuff didn't just go on. It resulted in people staying with the department after they graduated, became licensed. They worked themselves up. We have great opportunities for nurses in particular, and we're ignoring, according to the associate degree nurses who are like a third of the graduates, maybe higher of the percentage of people who pass the board. So thanks. I won't ask for an answer, but let's talk more about paid internships and paying attention to associate degree nurses. Thanks.
Thank you, Representative Terziak. Representative McCarty, followed by Representative Walker.
Yes, thank you very much, Madam Chair. First, I'd like to begin by just thanking all of the agencies for providing all the information, very useful and helpful. My particular concern is, we're going to have the new 988 call in, and I can envision a dramatic increase in more behavioral needs support. So I'm wondering if one of the agencies might comment on that, and if they can foresee that there will be more additional funds needed to, I see the mobile crisis enhancement, and I think that's a really important step in the right direction. But if we have more calls and more needs, is there a plan going forward to anticipate where those needs, how they will be met? That would be my first question, just mostly about mobile crisis enhancement. I do hear from many of the superintendents I know today is on the adult behavioral health, but we have that crisis with our students as well. So just perhaps a comment from someone about, do they foresee more need, and how are we going to handle that with resources?
So Representative, this is Nancy Navarrete from Demus. We did receive a small planning grant award and have been meeting with DCF because it's a lifespan, 988 is lifespan. So we're meeting with DCF, United Way, and with a diverse group of stakeholders really to plan this out for the future. And I think your point is well taken. We are anticipating that there will be an increase in calls to 211 through 988. And our plan is to gradually bring up more staff to both in the United Way and to answer the phone calls. We've given them quite a few dollars to be able to do that, and also on the mobile crisis side to be able to deploy people. So we're on that track.
And that's very good news, Commissioner. Could you just, and this is with the first question, I still believe that, do you have any idea of what the median time response is on the mobile crisis units? Is there some time frame that they need to respond to the calls?
Julene Giard is on the call from Demus. I think there are different benchmarks for adult and child. Julene, is it 90 minutes?
Are at 90 minutes. With the increases to the mobile crisis teams, we are looking at potentially reducing that maximum response time.
Thank you.
Okay, that does help. And then just quickly a comment on the recovery piece. I noticed, and I'm very pleased to see the use of telehealth services. Might you comment just about how you see that envisioning going forward with recovery particularly?
Yes, so we've, over the course of the pandemic, we have had federal dollars that have come in to be able to pay for things like equipment, both for clients and for staffs of our providers. Also, our state operated has really shored up their technology. So going forward, I imagine there will be more of a hybrid model. And some folks, it all depends on the person. Some people like that one-on-one face-to-face contact, and some folks prefer the telehealth option.
Mm-hmm. Thank you very much. I think I covered the two, although I have many more questions, but I'll get them to you. Thank you very much.
Representative Walker.
Thank you, Madam Chair, and I want to thank everybody for hanging in there for the last few questions. I just have one question. Do all of the agencies have a quality assurance department in your agencies? Demus, yes?
Yes, we do.
DSS?
Yes.
Yes, okay. DDS?
Yes.
Okay, who else goes in there? Kelly's gone. What I knew. Judicial. I know.
Yes, we certainly do. Yes.
I know you guys do. Oh, okay. Okay. Was there anybody? Oh, DOC, Department of Corrections.
Representative Walker, yes, we do.
Okay. All right. So the reason why I asked that question is because I would suspect that the contracts, especially for your mental health services and everything, I would expect that those contracts are reviewed on a regular basis because of the nature of our society and the fact that our needs change. And I'll be honest, I know some of you have contracts with agencies that have gone back 20 years. And so looking at the way we desperately need innovative and new ways of addressing mental health, I would beg all of you to pay a close attention to those contracts and to those providers to make sure that they are providing the state of Connecticut the services that are really current and needed in our area. So I plan on hopefully talking to most of you later on to present something about that in appropriations later on. So thank you very much. And thank you, Madam Chair, for letting me come back and ask one more question.
Thank you very much, Representative Walker. So we're going to start wrapping this up. Again, I know that Senator Minor has been paying attention, but his ability to talk is a little bit stymied based on the connection that he has. Representative France, do you have any last comments? I don't know if he's still on. I know that he asked a couple questions. I just want to, Vicki, did I appropriately represent the fact that this is only a small portion of the people that are using mental health services?
I'm sorry, in which program? Oh,
well, and relative
yeah.
to the fact that a lot of these people are paying for services through private insurance.
Yes, that's true. So just to clarify for the committee's purpose, what we have about 3.6 million people in the state of Connecticut. 25% of the current population is covered under Medicaid, I think, about that percentage. The remaining folks, I mean, we have a very small percentage that's uninsured in the state, somewhere around 4 point something uninsured. The remainder are in either Medicare or private health plans. The vast majority are in private health plans. About 2 million people in private insurance in the state of Connecticut, of which about 25% to 30% are in insurance plans that we regulate, meaning we can only touch about 25 to 30% in terms of regulation of those folks enrolled in those plans. The remaining portion of those people are enrolled in larger employer plans that are governed by the federal government and are regulated in that manner. So a lot of what we do, unfortunately, we can't regulate from the insurance side everybody who accesses mental health services. We can regulate from the provider side of the equation for the most part, but not from the insurance side of the equation for everything. I hope I might have given you more than you asked for, and I apologize.
I think so. And Senator McCrory, you're sneaking in under the line because we're just wrapping up. But do you have a question or a comment?
Yes, thank you, Senator. And I want to thank all the commissioners for presenting today. I think you guys did an excellent job. We've been on this call for over 2.5 hours. I appreciate everything that I heard. And I sat here and listened quietly. And my only commentary and concern is, and I'll be totally honest with all you guys, I haven't heard anything new or innovative. I haven't heard anything that we're going to do differently to change the course of reality for a number of people in the state of Connecticut, and especially those communities that have been underserved for so many years. And I will reach out to every one of you to have a conversation with you, to talk to you about how we can do things differently. Because I'm not sold on how we're operating. And one of the excuses that we normally use was, well, we didn't have enough resources, don't have enough dollars, or whatever the case may be. I don't think that's an issue. So therefore, when we do have resources, we have to be creative and new and innovative. And I'm not hearing that. But I will reach out to each one of you commissioners to have a conversation to work with you, because we have to do better. We absolutely have to do better. And I'm just thinking off the top of my head, we talk about mental health, and I'm thinking when we contract with our agency, your partners, which agency stays open at midnight? Which agency stays open when a person has a mental health crisis at 11 o'clock at night? Where do they go? Do we have 24-hour services in these communities? Especially these communities that have been impacted by opioids and this coronavirus. I don't see that happening. I don't see that in my community. And many of my colleagues I talk to, they're saying the same thing. So people talk about we don't want to reinvent the wheel. Hell, I think we need to reinvent the wheel. I think it's an opportunity time for us to reinvent a wheel. So I'll be reaching out to each and every last one of you, proving you concepts, ideas, or at least just have a dialogue to hear it from a bottom-up perspective. Because I'm really not confident and comfortable in the direction that we're hearing. That's all I wanted to ask. Also, thank you very much. And thank you guys. Again, I don't want to be negative. I don't want that to sound negative. I want it to sound opportunity. Sound like an opportunity that we can build and fix something, in my opinion, that's been broken for a number of years. Thank you.
Thank you, Senator. Representative Walker, do you want to wrap up? Any final comments?
I just want to thank again, like everybody has, thank you for coming and talking to us and being honest and sharing the strengths and the weaknesses that you are facing. And I hope that we can continue this conversation into the session and look at many ways we can collaborate and affect some of the fundings that we have out there in your area so that we can address mental health in a new and variety of ways. So thank you very much. And I think Madam Administrator is waiting for you.
I think she probably is too, but I just want to call Representative Kennedy for and find out exactly where she is, because we're all coming down to visit her as it's cold.
So I'm bringing you some sunshine from the Gulf of Mexico. I'm in the Riviera, Playa del Carmen. It's 85 degrees and sunny today. It rained all day yesterday. But a huge shout out to all of our presenters today. It's been so welcoming. And I'm very happy that Zoom works on the beach. Y'all be safe and be warm.
Thank you. You too.
Make her send us her address.
Yeah.
We're all going there. Madam Administrator, what do we have coming up next?
Well, Madam Chair, on this coming Thursday, January 13th, we are having a joint public hearing with the Human Services Committee on the federal applications that DSS is submitting to implement the Home and Community-Based Services Spending Implementation Plan, which is part of the American Rescue Plan Act. So we will be hearing the Appendix K disaster relief amendments to the 1915C waivers and the Medicaid state plan amendment for disaster relief. And a committee meeting to vote on these applications will be held immediately following the public hearing. The public hearing begins at 9 a.m.
All righty. Thank you very much, Madam Administrator. I hope you all enjoy the day. Thanks to all of the agencies who came today. This is an important issue that we have. I think it's been an important issue for years, but it's an extremely important issue. And I would point out that I think that having the base of this allows us to provide some resources to some programs. And I look forward to the next budget cycle, which happens in just about 3 weeks. So 4 weeks. So let's all prepare for a very short session that will happen in the blink of an eye. Thank you all very much. Have a nice day.
Thank you. Bye.
Thank you.